Good afternoon and welcome to today's Michigan Medicine Well Aware presentation. I'm Kelly Malcolm, lead research communicator for the Department of Communications, and I will be moderating today's event. Today, we're going to discuss telehealth, which has served as a vital link between healthcare providers and patients during the COVID-19 pandemic. What lessons have we learned about telehealth that will shape its future? What elements of telehealth will remain once the pandemic is over? How do we ensure that patients have access to the necessary technology to connect with their care providers? Will insurance continue to pay for it? And how do patients feel about telehealth? Thank you to everyone who submitted a question in advance. We will be working to answer many of those throughout the presentations and later during our Q&A. We also will be accepting live questions during the Q&A portion of today's presentation for those of you who are joining us through Zoom. Please use the Q&A feature to ask your questions, and we will do our best to get to as many as possible. Now, joining me today are Dr. Julia Chen, clinical instructor of internal medicine and virtual care lead for general medicine, discussing overall telehealth trends and its use in primary care. Dr. Michelle Moniz, assistant professor of obstetrics and gynecology, who will discuss prenatal care, the need for more research, and the good and harm telemedicine is doing. Dr. Allison Lin, assistant professor of psychiatry, discussing mental and behavioral health along with substance abuse, and Dr. Chad Elamutul, assistant professor of urology, director of telehealth for the Department of Urology, and the director of the University of Michigan's Institute for Healthcare Policy and Innovation's Telehealth Research Incubator, reviewing policymaking and how Michigan medicine is impacting the future of telehealth.
I'm Dr. Julia Chen, Virtual Care Lead for General Medicine. I'm excited to be with you today and to share our experience with telehealth at Michigan Medicine during the past year. Although telehealth did not begin with the COVID-19 pandemic, there were several regulations that limited the use of telehealth in the past. In particular, Medicare beneficiaries had to live in a designated rural area and travel to a hospital or a specific medical facility for telehealth. In addition, only certain providers, such as physicians, nurse practitioners, and physician assistants, could perform audiovisual, or better known as video visits. There were only certain services covered, with the majority of services having to be provided face-to-face or in person. Due to the COVID-19 pandemic, there has been temporary removal of some of these regulations, including allowing patients to receive telehealth services from any location, including home. Allowed providers and services were also added. So the emergency department evaluations, hospital discharge follow-ups, office visits, physical therapy, speech therapy, and occupational therapy services could be provided by telehealth. Importantly, there's equal payment and reimbursement for these services in-person visits. In addition, everyday communication technologies such as FaceTime or Skype were allowed, as not all healthcare offices or systems had video visit technology set up. At Michigan Medicine, we did have a video visit platform already in place, but had to rapidly expand the capacity of our platform to accommodate the increased number of video visits. Importantly, audio only or phone visits were also allowed, recognizing that not all patients have access to or the ability to connect via video visits, or that technology could fail at times. Some co-pays for virtual care were also waived. Nationally, this resulted in the number of Medicare beneficiaries receiving telemedicine per week to increase from 13,000 prior to the pandemic to 1.7 million as of the last week of April. At Michigan Medicine, the numbers increased rapidly as well. Here you can see over various 3-month periods starting in July of 2019, the volume of video visits that we were doing. Prior to the pandemic, over 3 months, we were only doing 400 to 700 visits. However, this increased rapidly once the pandemic started. As of the end of 2020, during the last 3 months, we were doing nearly 110,000 visits. At Michigan Medicine, we were well positioned to expand virtual care, having already begun planning for expansion prior to the pandemic. We had virtual care champions designated in all clinical departments and a dedicated virtual care team that was working closely with teams in health information technology, billing, and legal to understand the many changes in regulations early on. We also were able to communicate these changes to providers and staff through weekly question and answer sessions, an internal virtual care website, and regular email communications. Not only did video visits grow, but we also had growth in other forms of telehealth, including e-consults, e-visits, telespecialty consultations, and remote patient monitoring. As we've discussed, virtual care can take many different forms, and so we had to think creatively about how to continue providing the high quality of care the patients expect from Michigan Medicine in a telehealth setting. In primary care, we were able to develop a drive-through blood pressure check for patients with high blood pressure and a hemoglobin A1C check for those with diabetes. Our post-acute care services team also developed a program called Patient Monitoring at Home, where patients were provided with a kit, including a blood pressure cuff, pulse oximeter, and scale to monitor their vital signs more closely following a hospitalization. Abnormal vital signs were automatically sent as an alert to a nursing team who could reach out to the patients and check on them. These are only a few examples of the innovative programs that were developed rapidly to care for our patients at Michigan Medicine. One of the newly allowed services that I mentioned earlier were phone or audio only visits. While we expect video visits to continue even after the pandemic, the ongoing reimbursement for phone visits is less clear. As mentioned previously, this low-tech version of connecting with the provider can be particularly important for vulnerable populations without access to technology or difficulty using technology. Along with Dr. Chad Elamoodle and other colleagues, I reviewed patient demographic characteristics of those utilizing video versus phone visits during the early days of the COVID-19 pandemic from April to June. We found that older adults were less likely to be able to access video visits successfully. In addition, patients needing an interpreter, Black patients, and Medicaid recipients were more likely to use phone visits than video visits. Many of our patients had more than one of these factors that would make it less likely that they would be able to connect via video visit. We looked at some example patients to understand the cumulative effect of more than one factor on the likelihood that a patient would be able to connect. As you can see, patients over 65 with additional risk factors such as having Medicaid and needing an interpreter had a predicted probability of only 14% of having a successful video visit as compared to 84% for an English-speaking young person with a non-Medicaid insurance. More research is underway to understand the reasons for these differences. And now I'd like to turn it over to Dr. Muniz to talk more about their experience with telehealth in obstetrics and gynecology.
Good afternoon, everyone, and thank you so much for joining us. My name is Michelle Moniz, and I'm really excited for this opportunity to chat with you about telemedicine and the long overdue redesign of prenatal care in the United States. So every year in the United States, about 4 million women receive prenatal care. And some of you may have received prenatal care in this care model. And our standard model is depicted visually here on the slide. So the blue icon on the far left represents a phone call. This is our intake before your very first visit. And then each of the yellow circles are for in-person visits with our healthcare system. The orange icon there represents the ultrasound that we do midway through pregnancy. So this is our standard model of about 12 to 14 in-person visits for low-risk women, a variety of different services delivered at each of those visits. And when you start to scrutinize prenatal care in this country, what you quickly realize is that we have excellent evidence for each of these different services, for screening for various conditions, providing vaccinations during pregnancy, but how we deliver care, those 12 to 14 in-person visits, is much less well studied. And in fact, this has been our care model since the 1930s. Prenatal care delivery really hasn't changed in nearly a century now. And we knew that telemedicine was beginning to emerge as a model that might really be promising in prenatal care. It might increase flexibility for families. And there were some randomized controlled trials that were conducted that suggested promise of this modality. So specifically, we knew that prenatal care models incorporating telemedicine and fewer in-person visits delivered equivalent or sometimes better outcomes for moms and for babies. It also increased moms' satisfaction with their care and sometimes delivered cost savings for our healthcare system. So these data were quite promising, but we knew we needed additional investigation because these early studies were conducted largely with white women and with women living on higher incomes. So we knew more data was needed. But then the COVID-19 pandemic hit. And like many healthcare providers in our healthcare system, we were really trying to figure out how can we maximize social distancing, minimize our patients' contact with the healthcare system to help keep our patients and our healthcare teams safe. And in that context, my colleague, Dr. Alex Peel, led some great work reviewing the evidence base we had and proposing that we make a new prenatal care model in line with that evidence. And this is the new model that we rolled out. And you'll see that there are many more blue icons for virtual contact points and many fewer yellow icons for in-person visits. And Dr. Peel really clustered those critical evidence-based services often at these in-person visits with these important remote contact points in between. And we rolled out this model both at our healthcare system and really at healthcare systems across the country in the context of the pandemic. And it was quite rapidly adopted. On the y-axis here, you'll see number of visits in a given time period. And then each of the bars represents a 2-week time period from December of 2019 through June of 2020. And you'll see that line where we really started implementing changes related to the pandemic. And as in the post-pandemic period lines, you'll see that the blue lines have really diminished. Those are our in-person visits, and you can see the lengthening of the orange telephone contact and the gray video visit contacts. And currently about 15% of all of our prenatal care visits are delivered virtually. So this is really a model that was rapidly adopted and has persisted. And we've surveyed some of our patients, many of our providers, and have gotten really great feedback that people love having this flexibility and that the model's working well for them. We've also gotten some questions that have come up from both patients and providers. And this is an area where we think philanthropy can really help us propel the field forward. Dr. Peel's work is really setting the standard, not just here at Michigan Medicine, but for what's happening across the country with prenatal care redesign. And these are some of the questions that have come up. Which patients desire telemedicine visits and at what point during pregnancy? It seems like such a fundamental question, but we really don't know the answer. We also don't know what's needed to ensure that access to telemedicine during pregnancy is equitable across patients and settings for anybody who desires it. So, solutions may include policy solutions related to reimbursement for telemedicine services, reimbursement for home monitoring devices such as blood pressure cuffs that doctors or midwives may recommend for patients during pregnancy and postpartum. Other infrastructure may be needed to ensure that patients have access to devices and broadband internet so they can meaningfully participate in this new mode of healthcare delivery. We also hope to learn much more about how telemedicine affects the patient experience of care and whether there's variation in that experience across patient populations and whether we need to tailor care delivery models to the needs of different patient groups. We also need to better understand when it is or isn't appropriate to use telemedicine from a purely medical standpoint. There may be times where an in-person visit is much more appropriate. And I think the million-dollar question that we are all wondering is whether telemedicine, how it's going to affect population health outcomes, expenditures, and value. In the United States, we spend a lot on maternity care and have some of the worst outcomes among resourced countries. And so this key question of whether we can do better with the funding we're investing in this care and deliver better outcomes and a better experience for patients. That's a key question that our team is really interested in answering. I will leave you with this quote that only a crisis, actual or perceived, produces real change, in hopes that we all feel inspired to really leverage the hardships of the last year and produce better change for our patients and our healthcare system. So thank you so much for your attention, and I'm delighted to turn things over to my colleague, Dr. Allison Lin.
Hi, everyone. My name is Dr. Allison Lin. I'm an addiction psychiatrist here at University of Michigan, and my research focuses on telehealth for patients with substance use disorders. Substance use disorders, also known as addiction to different addictive substances, such as alcohol and opioids, is one of the top preventable causes of health problems and premature deaths in the US. Over 95,000 people die annually due to excessive alcohol use. And as many people have heard, the overdose epidemic in the US continues to accelerate, with over 70,000 people dying from drug-related overdoses in 2019. In addition to the impacts on mortality, we know that addiction also causes numerous other physical and mental health problems and has extensive impacts both on the individual struggling with the illness, but also often on families as well. One of the challenges, though, that we face when trying to address all of these impacts from addiction is the limited access to effective, high-quality care in the community. Although 21 million Americans in the US have substance use disorder, only about 10% receive treatment. This is lower than treatment rates for pretty much any other common medical problems, including other mental health disorders. There are several contributors to these low treatment rates. Even though we know the extensive impacts of untreated addiction, and even though we have highly effective treatments, the stigma surrounding it makes it really hard for people to talk about it. So addiction is very much under-recognized, and there's limited insurance coverage and funding to address it. Another challenge is the low number of addiction-trained physicians and other clinicians in the US. There are only about 3,000 addiction physicians across the country, and unfortunately, an even smaller number of addiction psychiatrists like myself. As one indicator of these access issues, this figure on the right shows all the counties in the US, and counties in gray do not have a single addiction psychiatrist. We're lucky in Ann Arbor to have the university, but as you can see, the majority of people in Michigan don't have access or must travel long distances, which is not feasible for many effective treatments for substance use disorders that require regular visits. These access challenges have also been magnified by COVID-19. Due to the increased stressors that we know a lot of people are experiencing, more folks are struggling with mental health and substance use problems, including key groups like parents, older adults, people who've recently lost jobs, and many underserved populations. There are signs that many people are turning even more to risky use of substances to cope. In Michigan alone, through our overdose tracking system, we've seen a substantial increase in overdoses across the state since the start of COVID-19. Thus, although I've been conducting research on telehealth for people with substance use disorders for over the past 5 years, a lot of this work has become even more pressing since the start of COVID. My research focuses on looking at impacts and gaps and disparities in telehealth care, but also designing and testing new virtual care treatment models. I'll briefly highlight 2 of these programs. First is the Michigan Opioid Collaborative and the Michigan Teleconnect program that I co-lead. These programs started about 3 years ago with 2 major goals. One is to better support non-addiction specialists, such as primary care and mental health clinicians across the state, to better deliver addiction care. And second is to use telehealth to deliver more treatment to patients suffering from opioid and other substance use disorders across the state. We have a team now of over 20 staff serving all of these regions in Michigan. And to date, we have trained over 600 clinicians to deliver medication treatment for people with opioid use disorders and have supported almost 3,000 clinicians and patients with substance use disorders across our state. The second program I'd like to highlight tries to answer some of the questions that focus on what are the new and better ways that we can use telehealth to try to help patients with substance use disorders in the future. We designed a new program called InReach, which directly tackles what we see are the current reasons for the huge treatment gap that I mentioned. First, we know there's a lot of stigma around substance use disorders, and the illness itself makes people who are struggling have a hard time seeing the impacts of their substance use and be ambivalent about reaching out for help. So through InReach, we are turning the traditional model of addiction care on its head. Instead, we are proactively identifying and reaching out to folks with untreated substance use disorders and delivering initial counseling via telehealth to help them increase their readiness and motivation to seek care and decrease the impacts of stigma. And then we know we have to make substance use disorder treatment more accessible and appealing, especially to underserved populations. So we're delivering evidence-based multi-session patient-centered psychotherapy through telehealth to meet people where they are across different backgrounds. Currently, we're pilot testing InReach here at University of Michigan, but our goal is to continue to make it better to make sure we're also serving the needs of groups with even greater disparities in treatment, including women, African Americans, and other underserved populations, and looking for future funding and support to roll this out and test it as a larger program. Thanks now for letting me highlight some of our telehealth work and needs for people with substance use disorders. Now, I'd like to turn it to my colleague, Dr. Chad Elamoodle.
Great, thank you. My name is Dr. Chad Elamoodle, and I'm going to be talking about my research, which is specifically informing national healthcare policies and specifically around telehealth policy. So a little bit about myself and my perspectives on telehealth. I'm a clinician, a urologist at Michigan Medicine who's been performing video consultations with my patients since about 2016. On the operations side, I've helped the Michigan Medicine virtual care program grow, but also our department's program grow substantially during the pandemic. And then on the research side, I direct the Telehealth Research Incubator, and that's the real focus of my talk today, where we study the population level impact of telehealth on cost, quality, patient experience, and access. And through all of these lenses, our goal is to help inform national policies. So not just the policies that are occurring at Michigan Medicine, but taking these lessons that we've learned and being able to inform policymakers across the country and shape telehealth policy for the future. And the truth is that telehealth is here to stay. This is an analysis that we did using Blue Cross Blue Shield claims in the state of Michigan. And we wanted to understand how telehealth has changed during the pandemic. And so during the early parts of the pandemic, telehealth was really the real main way that care was being delivered. It was about 50% of care. And that's that green line that you see in this figure here, that from March to June, you see telehealth growing. And then as in-person care started to come back, which is the blue line, you see that telehealth started to drop. But in essence, it landed at about 20% of care, which means that even currently now, 1 in 5 people are receiving healthcare through telehealth, which is a huge transformation of how healthcare is being delivered. It's not just at health systems. The market is growing for digital health. And you may have read a lot of articles about Amazon and other companies that are starting to build telehealth into their company portfolios. And so this is a big market that's growing. But unfortunately, there's actually not a lot of data in this area. We don't really understand what this means for a population. Is this going to increase healthcare spending? Is it going to improve quality of care? Is it going to improve access for patients? This was a letter that was written by senators to the leaders of the Senate back in June, which outlined the need for data, the need to look at what happened during the pandemic to help shape policies in the future. Some of the biggest policies that are out there right now, there's a lot of debate about what types of telehealth should be covered, should telephone calls be reimbursed, Should healthcare providers and patients be able to perform telehealth across state lines? How much should healthcare providers be reimbursed for this? And what's clinically appropriate for telehealth and what's clinically inappropriate for telehealth? So all of these factors are being studied right now. And that's really the essence of our research lab, the Telehealth Research Incubator. We want to understand at a population level, how is telehealth going to impact healthcare access? How is it going to impact healthcare costs? How is it going to impact healthcare quality? And how is it going to impact the experience of patients? And that's what we've been doing for the last 2 years or so. And over the last couple of years, we've had about 20 publications that are on these topics. We've studied various specialties, and we've also studied healthcare in general. And while many of these publications are out, we have a lot more that are coming out, and as after the pandemic has started, and there's a lot more to come from this in this area. And so, just to give you a flavor of the type of research we do, I'm going to go over one study that's coming out this month, and it was specifically trying to understand quality and also healthcare costs as it relates to telemedicine. So the way that we designed the study was looking at a population of patients that had upper respiratory infection symptoms like cough or cold. And you have a lot of options when you have that. You can have a telemedicine visit, or you can see your primary care doctor in person, or you can just stay at home and rest and relax. For the patient and for the healthcare system, having a telemedicine visit or an in-person visit may cost about the same. But what we were really interested in studying is what happens afterwards. Is the issue resolved? In that case, then those visits probably did cost about the same. Or was the telemedicine visit inadequate? If it was inadequate, it may lead to secondary visits through telemedicine. It may lead to more in-person visits. It may lead to an emergency room visit or an urgent care visit. And this is how we designed the study. And so when we looked at this set of data, what we found was that about 90% of these healthcare encounters actually required no additional follow-up. So they were resolved. And then what we did find was that there was a higher rate of a need for secondary visits if the visit was initially conducted through telemedicine when compared to an in-person visit. So this is going to be important moving forward as we think about what the role is in telemedicine. Is it a substitute for care, or does it actually lead to more downstream care? And this is going to be something that's important for policymakers to balance as we create post-pandemic policies. So I'm really looking forward to the session and answering questions around the population level impact of telehealth on cost, quality, access, and the patient experience.
Thank you to all of our panelists for your insightful review of telehealth trends and research. It's clear that telehealth is transforming the healthcare landscape. And now I'd like to invite everyone to the stage. Please note at this time that our presenters cannot give personal patient recommendations, but they can give generalized medical advice. We are now going to move into the Q&A portion of the webinar and take a few questions that were asked pre-event, followed by our live Q&A using the Q&A Zoom feature. So I'm going to wait for everyone to join. I think. Okay. So our panelists, our first question, what is it like to provide telemed visits as a physician? What do you like or dislike about it? And let me throw that to Dr. Muniz first.
Sure. You know, I have, unlike Dr. Ellie Moodle, I was new to providing telemedicine visits, and I love doing them. It feels like the modern day house call. I can see patients in their home, sometimes in their office, but with COVID, it's really been, for the most part, in people's homes. Their partner is often there. Sometimes their children are there, and so they can show you. They can carry the phone or their computer around their home and ask you questions about things. And it's just been really fantastic to have. It's a different level of intimacy with patients. And so I've loved that. I've loved being able to connect on that level. And I think for patients, they don't have to leave work, drive, find parking, pay for parking, wait for an hour in the waiting room to come in and see me for 10 minutes. And so patients have conveyed how meaningful it is for them to have that kind of connection without all of the busyness of connecting in person. And in some ways, it's a more mindful connection because they log on and they're really in a space where we can just talk directly. And so I've found it to be really fantastic. I've just really enjoyed it. And I think patients have too. The feedback's been largely really positive.
Great. And Dr. Chen, how about you?
Yeah, I've also really enjoyed telemedicine visits. I think especially, right now with COVID, when we're in the office, everyone is a little bit stressed about, trying to get things done quickly, not having the patients in the waiting room too long. We also, have to wear masks, both the patient and the provider in the office. And so we can't see people's faces as we normally would. And so during video visits, patients are comfortable, they're at home, we're both unmasked, and that really helps in developing the patient-physician relationship and addressing not just their medical issues, but also their mental health and building that rapport.
Excellent. Okay, for our next question, does research show that virtual care is just as or more effective in some cases? How is it how is the easier access to care helping or hurting patients? And how about Dr. Lin for that one?
Sure. So I think those are both really important questions. I would say by and large, the research has shown that telehealth is non-inferior, meaning it's that no worse than in-person care. But I would say that that is only one of the important questions. I think as we're finding now, it's really the potential of telehealth to expand access. So that second question, that's really important. And in particular, in some of our areas where there was so little treatment beforehand, especially for certain underserved populations. I think that's where the real potential is. However, there's really been much less research looking into those new treatment models that can actually expand healthcare through telehealth. So I think it's reassuring that telehealth by and large is not as is no worse than in-person care, but the real questions are around how do we use it? How do we really harness it to get more care to people who weren't receiving it before? And so I think those will be really interesting questions for the future.
Right. And oddly enough, our next question is sort of related to that. Is there any research that speaks to how telehealth is reaching a diverse patient population, for example, racially or with ethnicity? Are there any thoughts on how to make it more equitable? And how about Dr. Chen?
Yeah, as I was mentioning during my presentation, we have found that Black or African American patients, those needing an interpreter, are less likely to be able to do a successful video visit. We're still doing research currently about the reasons behind that. We do know from existing research that there may be less access to broadband, less access to devices, but we're trying to tease out how much each of those factors plays a role, because that directly will affect what measures need to take place to help improve that access. For example, if it's broadband access, obviously that's a much larger issue we need to deal with the community and broadband providers, not just within Michigan Medicine. But if it's access to devices or access to a quiet space, a private environment, or even access to healthcare devices like a blood pressure cuff or a scale needed to monitor, patients' weights or their blood pressure during pregnancy or with their other chronic conditions. Those are things that we have more control over. What we're also trying to understand is it a matter of comfort with technology and digital or tech literacy. And during the pandemic, it's been particularly hard because a lot of patients who might normally have support from family members or friends, or even from our health IT department, might be able to go in person to get help setting up something. That hasn't been possible because of the COVID pandemic in many cases. But as we get through this, it's important to understand how much of a role that was playing in limiting their access.
I did see another question about interpreters specifically, and our Michigan medicine interpreters have been doing a lot of work to connect with patients before the visit, and that has improved significantly our rate of successful connection because they're reaching out the day before to check with the patient. Do they have the app downloaded, or do they have a computer set up that they can do the video visit on? And that's been very helpful, that proactive outreach.
Great. So a question for Dr. Elamoodle. What is the future like for patients seeking telemedicine? How can patients advocate for telemedicine access when they are out of state? And we had a second question about how the location of the patient and the physician relates to telehealth.
Sure. So I'll take those two questions separately. First, just kind of related to the future. I think it's very hard to predict the future because we never expected us to be where we are right now in terms of virtual care. I remember when we were initially talking about the future of telemedicine, we thought, maybe in 5 years or 10 years, we would be where we are right now. So obviously things really sped up. With that said, I think one of the guiding principles that Michigan medicine has always had is that telehealth and virtual care should always be a optional thing for patients, never really mandatory. And I think that there's patients that have technical issues, but then there's also patients that just have a stronger preference to see their providers in person. And to be able to, it's important for us as we think about the future and how to scale this technology in various specialties. I think it's important for us to keep that front and center as we think about it. But with that said, I do think that more and more patients are going to consider this virtual first model, which essentially means that unless you need a physical exam, unless you need an office visit for a diagnostic test, or if you have a strong preference for it, then you may actually be able to handle a lot of your care needs virtually. And that is likely sort of the future, but not just at Michigan medicine. That's kind of where healthcare in general is going. We see that happen in many other industries, like the banking industry, where you don't need to go in to see a teller anymore. And so that kind of thing, that kind of trend is going to likely happen with healthcare in general. And I think Michigan medicine has had the infrastructure in place to be able to accommodate that for that, if that is the trend. So I think, that's what we think about for the future. And that topic of interstate telehealth, or the ability to see your practitioner across state lines, I think it comes up very often. There's a lot of our patients that will spend time in Florida during the winter. But then there's also patients that live just 45 minutes across the border in the state of Ohio. Unfortunately, that issue is very complex, and it's not just about state licensure, although state licensure is an important part of it. So prior to the public health emergency, a practitioner needed to be licensed in the state where the patient is located. So if I was in Florida, I'm licensed in the state of Michigan, I can practice medicine with patients in the state of Michigan, but it's really where the patient is located at the time of the visit. And so what that means is that these states are actually regulating whether or not you can practice medicine with the patients within that state. During the public health emergency, a lot of these regulations were lifted. State governors said it was okay to practice medicine as long as you have a license in any state. We don't know what the future is going to be. After the public health emergency, there's kind of a lot of issues related to this, but it goes beyond just state licensure. There's insurance rules. There's also other legal considerations too. So with that said, I know our team is considering this, or our team has this on their minds, and there is a work group that we're forming to look at the ability for patients to practice when they're on vacation, or to see doctors when they're on vacation and so forth.
Great. A lot of questions thrown at you there, so great answer. So our next question, what elements of health are monitored at home prior to telehealth for obstetrics? Broadly, what sorts of technology do we use to monitor patients at home to supplement virtual care? So we can go with Dr. Moniz for that.
That's a great question.
Yeah.
Thank you for asking that. When we think about remote monitoring, it's really quite different in pregnancy. So for many of our patients who are older, have chronic conditions, we may be doing much more intensive monitoring with wearable devices. For some patients who are working on health behavior change, diet, exercise, diabetes management, we may be monitoring steps and weight and blood glucose values. And for other patients with it, they may have more intense monitoring of their oxygen saturation and vital signs. In pregnancy, we're often dealing with relatively healthy people, and the monitoring tends to be more episodic, really associated just with the visit itself. So the current evidence base supports monitoring blood pressure and monitoring weight at the time of a virtual visit. And there's the most robust evidence for those types of monitoring. Sometimes patients would like to purchase a Doppler device so that we can listen to fetal heart tones at the time of a virtual visit. There's a less robust evidence base for that. We do not have an evidence base that suggests that we should be continuously monitoring fetal heart tones, mom's blood pressure, either during pregnancy or sometimes postpartum. We think about that. There is not a robust evidence base for that kind of intensive moment-to-moment monitoring at this time.
Did anyone else want to weigh in on monitoring technology? Okay, I think Dr. Moniz covered it. Okay, our next question. We discussed how providers feel about telehealth. What do we know about how patients feel about the experience of receiving telemedicine? And Dr. Chen?
Yeah, we have done, just as we do for our regular in-office visits, we did have questions specific to patient satisfaction regarding our telehealth visits about the ease of connection, how the experience was. And overwhelmingly, the feedback has been generally positive. As we learned and rolled out the process, in the beginning, there were definitely difficulties in connecting at times. We've developed various strategies to try to address that, both written communication and instructions prior to the visit, but also people reaching out proactively to the patients beforehand. As I mentioned, that's true for all patients who require interpreters, but also for patients not requiring interpreters. We're trying to do more proactive outreach to make sure they have what they need and understand what they need to do to connect, because obviously that's the first part of the visit. We are still doing some research about the patient experience, but we do have some upcoming seminars for providers about how to develop a rapport with patients during telehealth visits, which can be a little bit different just because we aren't in person, and how to really make their experience as good as possible to allow us to provide the same level of care that they expect.
Great. And we had a follow-up to the question for you, Dr. Chen, about closed captioning for telehealth visits at Michigan Medicine for patients with hearing impairment who may prefer not to use an interpreter. Is this something that patients will have access to?
Yes, this is something we're working on right now, actually. One of the issues, as you can see when you're on various webinars like this one today, is sometimes there are some mistakes in the closed captioning, and particularly with medical information and with medical appointments, we just want to make sure that that's as accurate as possible, and that we have a way to confirm with the patient that they're getting the correct information. We don't want them to get misinformation because the closed captioning isn't accurate.
Right.
But also I think there was a question about access to video visits for patients who are hearing impaired and they need to read lips. And sometimes, some providers may not do as many video visits, but we are trying to, in most cases, use video visits. I would say the phone visit is the backup, but that all providers should be trained and have the technology to do a video visit, especially if that patient needs it because they're hearing impaired.
Right. Okay, so we had a question about other forms of mental health care through telehealth beyond addiction care. Is psychiatric care well suited to virtual care? And if so, what's the future for it, including reimbursement? So Dr. Lin, do you want to take that?
Sure. So that's a very big question. I would say that, interestingly, much of the history of telehealth research actually started or began in mental health care. So telehealth for treatment of depression, PTSD, anxiety disorders has been very extensively researched for decades. I think there's good reason for that. In mental health, we really rely on, obviously, rapport between providers and patients, but oftentimes it's providing either psychotherapy or counseling or talk therapy, and medication management. So there's less of kind of the physical exam piece, although that still exists to some extent. So it's really been an area where it makes a lot of sense to do telehealth, and there's been a lot of research there. I think as such, that's kind of the area where we've shown that the outcomes are very similar, except there are obviously some things to consider, like Dr. Chen and others here have mentioned. That rapport is so important. The making sure that we are actually potentially having more, facial expressions and things like that, so that we're keeping folks engaged. That both patients and providers are not distracted, that they're actually setting aside a time and place for the visits. These are all really important things. I think in the future for mental health, when we think about telehealth, I can't help but notice like all the commercials that I now see where there's new counseling programs. Because the hard part is that no matter where you are in most places in this country, it's very, very, very difficult to get an appointment for mental health care. And so there are really good opportunities. At the same time, I actually think it's just as critical to be evaluating the quality of this care. What I would love to see for the future of telehealth is that we make as much out of it as possible in a beneficial way. But we still need to consider that there might be areas or ways that people might be using it that are not consistent with high quality care. And so I think all of that needs to be examined going forward.
Great, thank you so much. So our next question, what are some of the potential compliance and risk management issues surrounding telemedicine that may arise in the future once the relaxations to federal laws are lifted? What are some of the solutions to address these privacy concerns in telemedicine before the relaxations are lifted? And we'll go to Dr. Elamoodle and then anyone else who wants to jump in.
Sure. I'm happy to answer this question. It's a really good question because I know that patients are worried about getting hacked into these visits and so forth. And one thing I'll say is that during the public health emergency, there were regulations, compliance regulations that were lifted, although our system still followed those compliance regulations. Where our system is using the portal, the electronic medical record, so it has been very secure for our patients. There's less debate about whether or not those restrictions should continue to be lifted or if they should come back. I think most people think that it is important to have these visits highly secure, and usually there should never be any recording of the visit unless it's agreed upon by both parties and so forth. So I think that in healthcare, unlike other forms of video conferencing, it still should continue to be very secure. And I don't think that that particular regulation is going to necessarily go away. And I think that it will likely come back as soon as the public health emergency is over.
Okay, thank you. So what is the process like for a physician or department to select, purchase, and use a telemedicine technology? Dr. Elamoodle?
Sure. Yeah, happy to answer that. So I think for our healthcare system, it was most natural for us to use the technology that was already embedded into the electronic medical record. It's easier for patients because they're familiar with their portal. They can log in. It's easier for providers because we have direct access to the records, and it's easy for us to sort of track appointment times and so forth. So it made a lot of sense for us to use it. When you go out into the community, there are certainly different types of platforms that are available. Many platforms right now may not exist in a year or so when the regulations come back around privacy and compliance. But there are platforms that have pros and cons. But I think that the fact that we're able to sort of integrate and kind of keep a more seamless experience. It's not perfectly seamless, but I think a more seamless experience for our patients has been a big bonus for our system.
Great. Okay, our next question. How can we evaluate the quality of care delivered over telemedicine? Dr. Chin, do you want to take that?
Sure. So I think that that question is still being thought about and being answered and actively looked at right now. Because telemedicine was such a small portion of our practice prior to the pandemic, it was hard to really evaluate those outcomes on a large scale. But currently, as Dr. Moniz was mentioned, they're compiling information on their patients who use telemedicine for their routine OB care. We're doing similar research, for example, for diabetic patients. If they had, 1 or 2 telemedicine visits versus all in-person visits, was their A1C control better or not? So I think what we're at the stage where we're looking at chronic conditions and the outcomes for those specific conditions, as well as, rates of hospitalization. And, we are finding that some care was deferred during the pandemic, like routine colonoscopies, and unfortunately, we are seeing a rise in cases of cancer and polyps. So it is important to definitely continue to follow those as we implement telehealth on this broader scale.
Kelly, I could add on.
Yeah, go ahead.
Yeah, sure, certainly. So I think when we think about quality of care, there's 2 big components. The one component is patient experience as a measure of quality, and then the second component is clinical outcomes as a measure of quality. And for the patient experience part, I know that there's research that says that patients have high rates of satisfaction, but is the experience the same? Our colleagues at University of Michigan published a poll that surveyed adults aged 50 to 80, and the link is actually in the chat, where they found that 45% of the respondents felt that their rapport was not the same during virtual visits as it is in person. So, there are some disadvantages to the virtual component, but there could be potentially some enhancements too. So, for example, if you're conducting a video visit, I could pull up a video and show the patient the video of a procedure that they're going to have. If their son from California wants to hop in on the visit, they can do that easily through a link. So there are potential opportunities where we can make virtual care even a better experience than in-person care, but we're not completely there yet, but I think there's still a lot to learn. Then in terms of clinical outcomes, I think that, we've cited some studies that have shown that it's not necessarily inferior, but I think it does matter for what type of conditions that you're looking at and what type of patients that you're looking at. And I think down the road, what we have to see is that for virtual care to improve quality, there has to be some sort of underlying mechanism. So is virtual care being used to access or give access to patients in areas where they don't have physicians that treat their condition? Is it improving the frequency of interactions between the patient and provider? Is it giving patients access at a time when they don't have access? If there are those types of areas or mechanisms in place, then virtual care can improve quality of care. But I think otherwise, a lot of the interaction that we see is mostly a substitute for care, may not necessarily improve quality of care.
Right. Okay. So you actually kind of touched on this next question about rapport. Have there been any lessons learned on how providers should use their demeanor or, their background or aspects of their virtual environment to kind of build that rapport with patients?
Yeah, so I think rapport is a big part of these visits. So one of the things that I don't like doing new patient visits virtually as much as I like doing established patient visits where I already have good rapport with the patient. They already know me and we're just communicating some low complexity information. So I think selecting the type of visit is really important. But beyond that, there's this concept of website manner. So if during the visit, if you are during an in-person visit, if you are checking a patient's labs or looking through their chart, they see that because that's happening in the room with you. But during a virtual visit, you do the entire visit like this. And if you're not paying attention to that, the fact that you're off camera and that you have to sort of change your interaction during the virtual visit, it could be a poor experience for the patient. So I think those are the type of elements that you really need to pay attention to as you're doing these visits.
Great.
Kelly, I want to add on.
Yeah, go ahead, please.
I think it's so important too to recognize what Dr. Ellie Moodle said at the very beginning, that virtual care is an option, and there may be patients who really prefer an in-person visit. Our country's having a national conversation about systemic racism, and healthcare is not immune to that. And in maternity care, I see this all the time. And sometimes there are patients who historically have been marginalized by our system due to racism, class disparities, other reasons, and they feel mistrust of our healthcare system and feel more comfortable coming to see me in person. And I think it's so important that we make decisions together with patients about what is the best way to build a strong relationship. And some of that is website manner. I love that new phrase. But some of that is also making decisions that sometimes we need to be in person in order to meet a patient's preferences and needs.
Great. Okay,
I also
so
just
we have,
wanted to add.
yeah, go ahead, go ahead.
Well, so I think that is kind of the crux of the matter, having options for different people. And it's interesting. So pre-COVID, that wasn't necessarily the case. During COVID, that's not necessarily the case. It's post-COVID. Hopefully we build kind of those options in an equitable manner. The flip side that I also want to emphasize, though, is that one area of telehealth, so adding to what Dr. Ella Moodle said, were kind of those 3 or 4 different facets of telehealth and benefits. The one area that I think has been also unexplored is potentially using telehealth as a way to reduce stigma of patients seeking care. So in particular, in substance use disorders and mental health disorders, much of the barrier in folks coming or presenting to care, much of what kind of contributes to that 10% treatment rate is really how difficult it is to talk to someone about it. And I think
Right.
that's an area that has a lot of potential, not just in mental and behavioral health, but in lots of our, outpatient and general healthcare, where there are difficult topics, different things that patients, I think, have a hard time or ambivalence about talking to their providers about. And I think telehealth is one way to maybe decrease that barrier, but also we need to make it so that through telehealth, patients can also feel more comfortable. And that's where kind of the manner and the rapport of the provider really makes a big difference.
Well, thank you all so much, and to all our viewers, thank you as well. Before we conclude, I'd like to welcome Vince Cavatayo, Associate Director of Development for Michigan Medicine Development.
Thank you for joining us today for our discussion about telehealth and the future of patient care. We hope you all found this session informative and that you learned some things that might be applicable to your lives. We're grateful for the experts who shared their valuable time and expertise with us this afternoon. I also want to extend my sincere thanks to our wonderful donor community, and a special thanks to those of you who plan to support telehealth research. Support for telehealth research has never been more important. Your contributions will directly impact our team's ability to understand how virtual care impacts the lives of our patients and families. Simply put, your gift will be a foundation for the future of patient care. We look forward to keeping you well aware of our activities in the months to come. As a reminder, a recording of this webinar will be sent in a follow-up email to those of you who registered. There will also be videos of today's webinar posted to both our Michigan Medicine Facebook and YouTube pages. Please join us for the next WellAware webinar, The Impact of the Pandemic on Children's Mental Health and Coping Strategies, on May 13th at 1 p.m. Please stay safe and healthy this spring. Thank you again, and go Blue.